welcome to another episode from the Veterinary Medicine Digest. Today we are descending into the deep, often misunderstood world of the feline brain, a place where electrical storms can brew in silence and erupt with a violence that leaves owners and clinicians searching for answers. We are talking about feline epilepsy, a condition that for decades was whispered about as a rarity, but which we now know to be a significant and complex reality for 1 to 2% of the general cat population. In this deep dive, we will explore the cutting edge of treatment, the history of our diagnostic struggles, and the definitive showdown between two therapeutic giants, Imepitoin and Phenobarbital. Imagine a living room in a quiet suburb where a cat is resting peacefully on a windowsill. Without warning, the cat begins to vocalize in a way the owner has never heard, a sharp, ictal vocalization that research has linked to an increased likelihood of structural brain disease rather than a simple idiopathic origin. The cat might begin to salivate profusely, a sign that conversely points toward a higher probability of idiopathic epilepsy, suggesting that the origin of the seizure might involve diverse brain areas such as the frontoorbital cortex or the cingulate gyrus. The owner is paralyzed by fear, watching what they believe is a rare event, but historical controversy regarding the existence of idiopathic epilepsy in cats is being dismantled by modern science. We now understand that more than half of the cats presenting with recurrent seizures may actually have idiopathic epilepsy, which is a disease in its own right. To understand the treatment, we must first understand the topography of the disaster. In recent years, researchers have turned their attention to the entity known as temporal lobe epilepsy in cats. This is not just a random firing of neurons. It is a syndrome where discharges in specific parts of the temporal lobe elicit very consistent semiology, justifying the use of a single name for these events. We often see histopathological changes in these patients, usually manifesting as hippocampal necrosis or later as hippocampal sclerosis. The epileptogenic potential of these temporal lobe structures has been recognized since the 1930s, though it has taken decades for this knowledge to be fully integrated into clinical practice. We now utilize a 6-stage system to describe the sequential progression of these seizures, which begins with simple staring and attention-seeking behavior and can escalate to generalized convulsive tonic-clonic seizures. Knowledge of this staging system is a vital tool for any veterinarian, as it increases the awareness and recognition of temporal lobe epilepsy, which fits perfectly into the seizure syndrome axis of investigation. The diagnostic journey is a gauntlet of exclusion. In the world of feline epilepsy, the term idiopathic epilepsy is often used interchangeably with epilepsy of unknown origin, emphasizing that the diagnosis relies on normal findings in both interictal clinical and neurological examinations. There is a certain level of uncertainty that always accompanies this diagnosis because it remains a diagnosis of exclusion, and we currently lack confirmatory tests like the genetic tests available for certain dog breeds. For a long time, the veterinary community believed that almost all cats with seizures suffered from structural brain disease, a belief that led many to assume idiopathic epilepsy was nearly non-existent. However, 3 large retrospective studies encompassing over 200 cats found that 33% could be classified as having idiopathic epilepsy. This shift in understanding has forced clinicians to look beyond the surface, utilizing the mnemonic vitamin D to categorize possible etiologies, including vascular, inflammatory, toxic, anomalous, metabolic, idiopathic, neoplastic, and degenerative conditions. The stakes in these cases are incredibly high because each seizure has the potential to increase the number of epileptic foci in the brain, essentially rewiring the organ for more disasters. This is why aggressive therapy is recommended as the response to treatment, rather than the initial severity of the seizures is the true indicator of long-term prognosis. When a cat presents with more than one seizure within a 6-month period, or if they experience the terrifying reality of status epilepticus, maintenance therapy becomes mandatory. Status epilepticus is a true medical emergency where continuous seizure activity for more than 5 minutes can lead to hyperthermia, hypoxia, and eventually multi-organ failure. In these moments, the choice of drug is not just a clinical preference, it is a lifeline. Intravenous diazepam or midazolam are often the first-line defenses used in the hospital, with midazolam frequently considered more potent or safer due to its faster onset and reduced risk of respiratory depression compared to other benzodiazepines. Yet, the long-term management of these patients often brings us back to phenobarbital, which has long been the drug of choice for cats with multiple seizure episodes. It is an effective anti-epileptic drug with an elimination half-life in cats of 34 to 50 hours, usually given twice daily. However, phenobarbital carries a heavy reputation, particularly among dog owners, due to its known potential for liver enzyme induction and hepatotoxicity in the canine species. In dogs, phenobarbital causes a proliferation of the smooth endoplasmic reticulum in hepatocytes, which increases liver weight and accelerates the metabolism of various drugs. But the feline liver is a different landscape entirely. A retrospective review of 4 veterinary centers found that phenobarbital administration did not result in hepatic enzyme induction or significant biochemical abnormalities in cats. This finding strengthens the safety profile of phenobarbital as an anti-seizure medication in our feline friends, as the induction of serum liver enzymes is not expected due to the low activity of the cytochrome P450 subfamilies in cats. Despite its safety, phenobarbital is not without its side effects, which can include sedation, ataxia, and weight gain secondary to polyphagia. In rare cases, more severe idiosyncratic reactions occur, such as blood dyscrasias like leukopenia or thrombocytopenia, though these are typically reversible if the drug is discontinued. This has led researchers to look for alternatives that might offer the same efficacy with a lighter side effect profile. Enter levetiracetam, often considered a second-line anticonvulsant that shows great promise even as a sole therapy. Levetiracetam works by binding to the synaptic vesicle protein 2A, and it has the unique ability to retard electrical kindling in the brain, potentially preventing the progression of the disease. It is rapidly absorbed with nearly 100% bioavailability, making it a safe and effective adjunct to phenobarbital in cats who are not adequately controlled. But the real game changer has arrived in the form of Imepitoin. A systematic review of anti-epileptic drugs in cats concluded that while phenobarbital was the traditional first choice, Imepitoin might be supported by a stronger level of evidence regarding its safety. This set the stage for a landmark multi-center, single-blinded, randomized, and placebo-controlled study designed to compare these 2 heavy hitters head-to-head. This study, which included 37 cats over a 15-week evaluation period, aimed to find out if Imepitoin could serve as a viable alternative to the long-established phenobarbital. The researchers focused on monthly seizure frequency, monthly seizure day frequency, and the occurrence of cluster seizures as their primary outcome measures. The results of this showdown provided fascinating insights into the feline brain's response to medication. In the Imepitoin group, monthly seizure frequency was significantly reduced from a pre-treatment mean of 6.1 to a post-treatment mean of 3.0. The responder rate, defined as those cats experiencing a 50% or greater reduction in seizures, was 62% for those on Imepitoin. However, the phenobarbital group showed an even more dramatic shift, with monthly seizure frequency dropping from 8.1 down to 1.3 and a staggering responder rate of 90%. When the two were compared directly, phenobarbital was associated with a significantly longer time to the first seizure event after starting treatment. This suggests that while both drugs are effective, phenobarbital might provide a more immediate and robust suppression of the electrical fires in the brain. The safety data from this head-to-head trial also offered some surprises. While previous reviews had suggested Imepitoin was the safest drug available, this specific study found that adverse effects were common in both groups, affecting 88% of those on Imepitoin and 90% of those on phenobarbital. The Imepitoin group primarily experienced ataxia, and interestingly, a significant number showed increased alanine aminotransferase activity in the blood. This finding was unexpected, as a previous pilot study had not detected any impact of Imepitoin on the feline liver, and it suggests that periodic biochemical monitoring is necessary even for this newer medication. In the phenobarbital group, lethargy and ataxia were the most frequent complaints, but these effects completely subsided in 60% of the cats by the end of the study. One of the most poignant aspects of managing feline epilepsy is the impact on the owner's quality of life. The sudden onset of a seizure can cause great emotional distress, and the commitment to lifelong 2 or 3 times daily medication is a significant burden. We must also consider the hidden dangers of autoimmune encephalitis, specifically those associated with antibodies against leucine-rich glioma inactivated 1. These cats often present with focal seizures, clustering, and behavioral changes, such as unprovoked aggression. In these cases, the standard anti-seizure drugs may not be enough, and immunotherapy with prednisolone can be a vital part of the management plan, though cats receiving steroids in the acute phase often represent the most severely affected individuals. The prognosis for these autoimmune cases is often tied to the number of seizures at presentation and the severity of hippocampal changes seen on magnetic resonance imaging. As we look at the broader epidemiological landscape, we see that aging is a significant risk factor for recurrent seizure disorders in cats. Data from primary care practices in the United Kingdom show that cats aged 9 to 12 years have over twice the odds of developing these disorders compared to younger cats. This underscores the importance of a thorough diagnostic workup as a cat matures, as older cats are much more likely to suffer from structural epilepsy caused by intracranial neoplasia or vascular disorders. Brain neoplasia, particularly meningioma, is the most common cause of structural epilepsy in our older feline patients, mirroring findings in canine populations. This makes the use of advanced imaging like magnetic resonance imaging particularly useful in older cats, as a normal interictal neurological examination does not entirely rule out the presence of a silent brain lesion. The diagnostic utility of a cerebrospinal fluid tap is another area where we must weigh risk against reward. A retrospective study of 87 cats found that in those with unremarkable magnetic resonance imaging or only hippocampal signal changes, cerebrospinal fluid analysis was normal in over 95% of cases. This suggests that a spinal tap rarely changes the diagnosis or management for cats who appear normal on imaging, a finding that mirrors data in canine idiopathic epileptics. Given the risks of iatrogenic brainstem injury or subarachnoid hemorrhage, clinicians should carefully consider the benefit before performing this procedure in cases where imaging is negative. It is also worth noting that in cats with postictal imaging changes, the cerebrospinal fluid is typically unremarkable or shows only very mild pleocytosis. We must also touch upon the special case of temporal lobe epilepsy and the role of the hippocampus. Signal changes in the hippocampal region on magnetic resonance imaging are frequently consistent with hippocampal necrosis on histopathology, but the cause or consequence debate continues. Does the seizure cause the damage, or does the damage cause the seizure? Both are likely true to some extent, and this has led to the emergence of surgical options like partial cortico-hippocampectomy for cats with refractory temporal lobe epilepsy. While this technique is still in its infancy in the veterinary field, it represents a bold new frontier for cats who do not respond to traditional pharmacological management. However, the loss of hippocampal function, which is vital for memory and spatial orientation, remains a major concern for both owners and surgeons. In the heat of an emergency, when status epilepticus has reached the refractory stage, we must turn to anesthetics like propofol or ketamine. Ketamine is particularly interesting because it can increase blood pressure, potentially counteracting the cardiovascular depression caused by other anesthetic agents. In some cases, a combination of ketamine and dexmedetomidine, along with controlled mild hypothermia, has been used to terminate superrefractory status epilepticus in dogs, and similar strategies are considered for our feline patients when all else fails. Even more experimental are non-pharmacological interventions like vagus nerve stimulation or deep brain stimulation, which might one day serve as a last resort for cats with drug-resistant epilepsy. Despite the advancements, we are still operating in a world where much of our knowledge is based on weak evidence compared to human medicine. We urgently need systematic studies to standardize electroencephalography protocols for cats, as this remains the only way to truly confirm the abnormal, synchronous neuronal activity that defines a seizure. Until then, we rely on the clinical acumen of veterinarians, the dedication of owners, and the evolving evidence from randomized controlled trials. We have moved from a time when idiopathic epilepsy was a myth in cats to a present where we have multiple safe and effective drug options and a much deeper understanding of the syndromes involved. The battle between Imepitoin and Phenobarbital is not about finding a single winner, but about expanding the toolbox for feline practitioners. Phenobarbital remains the heavyweight champion for efficacy and rapid control, but its side effects and the need for frequent blood monitoring leave room for Imepitoin to serve as a vital alternative, particularly for those cats where ataxia and lethargy are intolerable. Both drugs have proven they can significantly reduce the seizure frequency and improve the lives of cats suffering from this debilitating condition. The journey of the feline epileptic is one of long-term care, constant monitoring, and a deep partnership between the veterinarian and the owner. As we conclude this deep dive, let us remember that every data point in these studies represents a cat like Luna, whose world was turned upside down by an electrical storm in her brain. Through the rigorous pursuit of science, from large-scale epidemiological studies in the United Kingdom to blinded trials in Hanover and Ghent, we are bringing light to those dark corners of the feline mind. We are moving toward a future where a diagnosis of epilepsy is not a death sentence, but the beginning of a manageable chronic condition, where the goal is a high quality of life and the preservation of that unique feline spirit. Thank you for listening. The titles for the referenced papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.